Hi, I'm Dr. Jennifer V. Brown, your stroke specialist, and I'm aging gracefully with the stroke diagnosis due to sickle cell disease. And today I want to discuss, are you isolating and training the horizontal and vertical components of sit to stand after stroke? So we know during the horizontal component, there are some key muscle activities. Your feet move posteriorly, and that's due to the hamstrings. When this occurs, your tibialis anterior fire because there's closed chain dorsiflexion. When the trunk is erect and it's moving forward, the iliopsoas is in charge of pulling the body forward. That center of mass, which is in between the base of support, which is your feet, your ischiotuberosities, portion of your gluteus maximus, your buttocks, and any part of the thigh that's on the chair. For the vertical components, the key thing now is that you have to have liftoff. How do you get it? Your gluteus maximus and your proximal hamstrings are on stretch for the mere fact that your trunk is inclined forward. And then as you become vertical, your posterior calf muscles move the tibia backwards. Your proximal thigh, the portion nearest the hip joint, moves forward, and full knee extension is the last thing that happens. So, how do I train these movements? So, for the horizontal component, I start off with hamstring work. I make sure the muscle works concentrically, pulling the ankles backwards, and then holding it because you got to get your body forward once the feet are in place. And then I allow them to work eccentrically, slowly out. Next, I focus on the trunk. I have them pull forward and hold it there, and then go back slowly against the resistance of the band. Every opportunity I get, concentric, isometric, and eccentric work. Last, I work on scooting. So I want the feet in place, lots of movement around the ankle as the body moves forwards and backwards. I'm trying to train the timing of the tibialis anterior with the posterior component muscles of the calf. Now for the vertical portion, quite easy to do. I add TheraBand across the pelvis. And because we're already leaned forward, there's a stretch on the gluteus maximus and the proximal hamstrings. And so I do these um, explosive movements vertically while the trunk is angled forward. You got to get that lift off. And then next, I focus on getting the tibia backwards using concentric work. Notice I am facing the chair and the tibia has to move back against the resistance of the TheraBand. I often see people bring their trunk forwards, stand and straighten their knees, and they stay flexed at the hip, and then they right their trunk. Incorrect. You try to get lift off first, squeezing the buttocks forward as the tibia moves backwards, and then knee extension is the last movement to occur. Full knee extension. So, what are some questions we have to ask? Is there dynamic stability of the trunk so it can maintain an upright, erect position as the hip flexors bring it forward? Is there weakness in key muscle groups? The hamstrings, the hip flexors, all right, the knee extenders in closed chain, the ankle dorsiflexors, closed chain, the plantar flexors, closed chain. Is the seat height optimal for sit to stand based on the leg length? Just because you do the 5 times sit to stand test and the 30-second sit to stand test based on the chair height dimension given in the test, make it functional, efficient, and effective for the person. Use the chair height that's optimal for their leg length. Is the solid ankle AFO blocking leg and ankle movement during the horizontal and vertical components. And this could be a hinged AFO. Maybe the people are not strong enough to work against the force of the hinge. Easy fix. Loosen or remove the strap at the tibial portion and the part that's crossing the ankle. You're blocking the tibialis anterior from firing. And are there other systems issues compromising sit to stand? Sensory, proprioception, visual, perceptual. Maybe they have a midline shift syndrome or neglect of the space to one side of their body. Are there cognitive issues? These are all clinical questions that need to be considered when training for sit to stand. Remember, I'm your trusted source for all things stroke neurorehabilitation and ankle foot orthoses. These videos are released every Tuesday and Thursday. Like, share, subscribe, and leave a comment. Don't forget the references. We have to engage in evidence based practice to improve the outcomes for our clients. Thank you so much for watching this video. See you next time. Bye bye.